Hey, welcome everybody. My name is Logan Plaster. I'm the Chief Content Officer at Startup Health. Excited to be moderating this panel today. Panel's called Views from the Top, and we've got a really nice, diverse set of perspectives in healthcare leadership across health systems, big tech, big pharma, and we're gonna talk about big challenges and big opportunities. We've got David Holmberg, CEO of Highmark Health. We've got Dr. Janice Nevin, the CEO of ChristianaCare. We've got Dr. Michael Howell, the Chief Clinical Officer at Google, and we've got Diogo Rao, the Chief Information Officer at Eli Lilly. So, two big objectives for today's conversation. Obviously, these folks are, or you all, I'm gonna try to talk to you and keep this conversational. You are helping to helm health transformation today in many ways. And so part of the goal here is to pull back the curtain on how you're thinking, where you're steering, maybe some of the icebergs that you're seeing, and how to avoid them. But we also want this to be a conversation, a convergence of your own ideas, because my guess is you don't have many opportunities to be on a Zoom call with the four of you and to bounce ideas between health system thinking, pharmaceutical innovation thinking, what Google is working on. And so as we go through some of these sort of high level issues, I also want to hear some crosstalk and some conversation. So let's start with some basic introductions. We're gonna go down the line, starting with David. Tell us about your role and tell us one of your biggest objectives in the business for 2025.
Well, I'm David Holmberg. I'm CEO of Highmark Health. Highmark Health is a integrated health system and health plan based in Pittsburgh. So, we're the blue plan for 4 states. We also have a hospital system with 14 hospitals in Western Pennsylvania. And we have a technology company that, is pretty advanced in terms of capabilities and the work that we're trying to do. From our perspective, the biggest challenge, obviously the environment we're in is very difficult right now. And, we believe very strongly that in 2025, we've got to start to move some things forward and be different and innovate and maybe show progress on some of the consumer things. And just to give you a perspective, I'm a very unconventional healthcare CEO. I started my career in the jewelry business, ultimately got into the optical business, and that's how I ended up in healthcare.
What's one thing you've carried from being a jeweler to being a head of a health system?
Well, when you're selling, first of all, I am very popular at Christmas time because I can get you out of trouble, whatever trouble you've gotten yourself into. For me, it's when you're selling jewelry, you're selling something that people want but don't need. And in healthcare, they need us, but sometimes don't want us.
Interesting.
And so we have to figure out a way to meet people where they're at, treat them like consumers, maybe break the paradigm of a health insurer or health system or pharma company, whatever it might be, and take a different approach than's been done.
Nice. Dr. Nevin?
Thanks. Good afternoon. Dr. Janice Nevin, I'm the president and CEO of ChristianaCare. I am a primary care physician by training, grew up with the biopsychosocial model of care, and so firmly believe in how care needs to be integrated in order to achieve health. And I think, again, when we think about technology, there's a great opportunity with technology to help us do that. We are a large, regional, community-based academic health system. We take care of people throughout the state of Delaware, as well as in the contiguous counties in Maryland, southeastern Pennsylvania, and New Jersey. We are very committed to population health, to value-based care. We believe that there is a better way to care for people to really drive health, that the hospital should be the place of last resort. And again, as I think about the future, think about 2025, again, I just think there's an incredible opportunity given the time in which we find ourselves, the technology that's available to us to really help solve for some of the very troubling issues that we have in healthcare, whether it be our ability to care for a significantly growing elderly population, where an ability to support our workforce, which is dwindling and has significant issues with burnout, and also to solve for the financial issues so that we can make care more affordable. And that's really where we're focused.
Thanks. Dr. Howell?
I'm Michael Howell. I work at Google. I'm the company's chief clinical officer, which if it sounds like a made-up job title for the best job in the world, it's possible that that's true. And my teams work across the things that Google does that have an important impact in health. And so those are things like, a few 100 million people a day come to search, ask questions about their health. There are around 200 billion health-related YouTube videos that are viewed a year. There are 8 billion people on the planet. But also I work with enterprises through Google Cloud, through inventing new kinds of math. 2 of my coworkers last month received their Nobel Prize for protein folding. And then I come from a background of, I took care of sick people for a long time. I'm a pulmonary and critical care doc, and between 1995 and 2017, I was either training or practicing as an ICU doc, and then ran parts of health systems. And so I would say that, the things to know about us are, we have 6 products that more than 2 billion people use every month. By definition, that tells you that we have to think on a global scale. And that the other is that as we invent new kinds of math and new kinds of AI, we work really hard to make those available for other folks to build on top of.
Quick follow-up. Where do you see Google Health on YouTube sort of shifting vis-a-vis the Google TV sort of announcement and kind of where that's heading?
Yeah, there are a few things. So one is in the health information quality space there. We've worked with the National Academy of Medicine and the World Health Organization, who defined principles for what high-quality health information is. And so, if you search for the most common queries, you'll see this thing at the top that says, from health sources. And then we'll tell you, that this video is from, ChristianaCare, which has licensed hospitals in the United States, or for doctors, nurses, and licensed mental health professionals, it will tell you it's a licensed physician or a licensed nurse. We do actually go verify licenses and things like that. And then I think the other thing that we've worked on really hard for accessibility is related to language. And so we have AI tools that help people move from their native language to more than 100 other languages in a way of really expanding availability of high quality information.
Okay. Diogo Rao, what are you working on?
Great. Hey everyone, my name is Diogo Rao, and I'm at Eli Lilly and Company. We are a company that makes medicines, and my job is to run technology, run everything from the technology that we use in discovery to the technology we use in the consumer experience. Speaking of the consumer experience, it's awesome to be here at CES. I've had a grin on my face all day as I've seen all kinds of really cool technology. Actually, I see a few people out there smiling right now. Now, let me ask you about the last time you got medicine. Did that make you smile? Especially when you had to pay the copay? I bet not. That is something we need to change. This industry is stuck in the wrong century. We need to modernize this consumer experience. At least bring it into the late 20th century. Actually, I'd really like to bring it into the 21st century, but it's time to change that consumer experience. That's really the problem that I want to go after this year.
Awesome. Okay, I want to start our conversation, although it's already begun, talking about the greatest challenges you're seeing in health and in health innovation within your sphere. At Startup Health, we coach hundreds of founders and often come back to the traditional SWOT chart, the understanding that if you understand your weaknesses and threats, it opens up opportunities for innovation and expansion. And so I really want to go down the line and talk about the greatest challenge that you're seeing in 2025, and then we'll come back around towards kind of how that opens up opportunities for innovation. So David.
Well, the greatest challenge we're seeing in 2025 is, we have a big portion of the country that's not satisfied with the healthcare system, and that includes all of us. And, we all, and I think you have this in this panel, we all represent different components of the healthcare system. We have the financing of care, we have the delivery of care, we have technology, we've got pharmaceuticals. Pharmaceuticals are running 30% of claims expense today, and that reflects the success and the work that they're doing to create super drugs and things that are going to make a difference. And the biggest challenge we see is we're all working in silos. If we want to change healthcare in 2025 and beyond, we've got to get at the table together and work on some of these things in a collaborative front. And that's what we were talking about before we started today is, we're working with Christiana in Delaware on some unique things. We're working with Lily on some unique things. But I do believe that's the biggest challenge is we're all in silos, we all have more data than we know what to do with, and we're lacking insights because we're not on the same team on any given issue.
Okay, and a reminder that if anyone wants to jump in on a response, you're welcome to. So Dr. Nevin.
Yeah, I would just really underscore that. I was going to say it at some point. I think not only do we function in silos, we tend to point fingers at each other. And I think, if we've learned nothing over the last couple of months, we really need to come together and start bringing our collective capabilities to the table to solve for what are very real challenges. I spend an awful lot of time thinking about people. Being a health system provider, we are either taking care of people, families, communities, or we have people who are that we have to take care of who are fulfilling that role. And as I mentioned in the opening, it's becoming increasingly challenging for people who need care to be able to access care. And so we really have to think creatively, innovatively, think about how we use technology to support our people so that they can do what they came to healthcare to do, which is provide that human touch. Technology is an absolutely essential, critical tool. We need to figure out how to use it in ways that are going to have impact. But when someone is suffering, they want that human touch, and we need to ensure that we will be able to do that. We've done a couple of things at Christiana Care in an effort to meet that challenge. I think the promise of ambient voice and in helping solve for some of the administrative issues that result in burnout. I'm very excited about that. We also have deployed Moxie. Moxie is a collaborative robot. Moxie essentially takes non-value added tasks off the hands of bedside nurses. And to date, I think Moxie has saved something like 8 million hours of work for nurses and patient care technicians. So again, we've got to think, ultimately in healthcare, we take care of people, and we need people. We'll never have enough. So I spend a lot of time, thinking about, worrying about how the people that we serve are going to be able to get the care that they need, and how I and we can do a better job of supporting those that provide that care.
Michael, maybe you can lean in on some of the AI challenges that you're seeing and how that even feeds into, I think what we heard were people challenges and silo challenges, community challenges, but then on the tech side, I think you and Diogo can feed into that.
Technology is a tool, right, to solve a problem. And so what is the problem? I think I would probably say the same thing, that patient-centered care, by definition, doesn't care where the patient is. We should take care of them whenever they need it with as little effort and as little expense as possible to create the most health on the planet. The WHO says that 4.5 billion people don't have access to essential health services. That's not only outside the United States. If you talk to medical schools who are recruiting faculty, they can't find primary care with a reasonable wait time for the faculty that they're recruiting. And it's not because the doctors aren't working hard, or the nurses aren't working hard, or the physical therapists aren't working hard, or the pharmacists aren't working hard. It's because of the system that to quote Don Berwick, the system that we have is perfectly designed to achieve the outcomes that it achieves. Sure. And so we need to think about that, I think. And technology is an important tool for that. AI is a foundational general purpose technology like electricity or connectivity. And so it may have impacts across all of those. And certainly we see the early targets being eliminated. I can tell a fellow lean practitioner over here, eliminating the non-value added work that is a huge part of being successful in healthcare.
So just to follow up quickly, that's sort of like the macro challenge. I'm curious, as you look at 2025 in your specific work, what's a specific challenge that might keep you up at night?
Yeah, 2023 was the year of people experimenting with large language models. 2024 was the year of many leading healthcare organizations getting real value out of generative AI. 2025 is the year of agents, by which I mean the models begin to do things in the real world around them with use of tools and other systems. That's a whole new set of challenges that will require a lot of change management for use in healthcare and in every industry.
Okay. Diego?
Well, a lot going on in 2025, but if I had to put one thing out there on the radar, it's around the safety of our medicines. Now, that's not a hot, sexy topic, but it actually is really important right now because something big is happening in our world. That is the rise of the medicines to treat obesity. There are a couple on the market. There are many more coming. These are expensive medicines that many plans choose not to cover, so that means the cash price is really expensive. What happens when you have a hot product that's really expensive? You start getting a lot of fakes out there. Now, it's one thing if you get a fake movie and or get a copy of something or a fake handbag. How much harm is that really going to do? When you're talking about a fake medicine, something that you inject in your body, at best, a fake medicine is going to do no harm. At worst, the consequences could be absolutely catastrophic. This is something we are just at the beginning of, and I think we need to start turning our focus to it in 2025 because this industry really needs to change. This industry, the medicines industry and the healthcare industry, has a terrible history if you go all the way back 150 years, like around the time that Lilly was started. Lilly, in fact, was started to counteract snake oil and all the fake medicines that were out there. We are about to hit that again, thanks to the rise in medicines to treat obesity, the economic potential for counterfeiters out there. So we're working on that really hard. We've got some really cool consumer kinds of technology we'd be happy to talk about, bringing in NFC and other things like that. But this is something that we're going to have to address before people get hurt in a big way.
I want to talk about tech convergence. We're here at CES, and one of the really exciting things about being on the floor is that the health tech zone is next to the vacuums, the home tech, and you can go see the auto tech, personal wellness tech, and the worlds collide. And so when you're in health, you start to connect these dots. You start to see how this should play with that, should play with this. Or how it should and it never does. So you start to see the gaps as well. So I'd like to go down the line and hear what convergence you would like to see happen. Maybe it's something that you'd like to have somebody pitch to you, and maybe you're seeing elements of it, maybe it hasn't happened yet, but how would you like to see the dots connected based off of some of the tech you're seeing here, David?
Well, I mean, it's been a fascinating few days. I mean, I had a chance to walk the floor, and there was a lot of tech that's looking for a market. I was, looking at the tech and saying, okay, how do we solve an existing problem that's in the healthcare system that we're trying to deal with? And being both a payer and a provider of care, we get to see both sides of the equation, and when it's out of balance, I mean, it can be devastating. So what I'm excited about was, I truly believe that if we're going to get this right as a country, we're going to have to innovate our way out. And the way that'll happen is by, getting the smart people in the room and saying, these are the 5 problems that are most relevant, that could make a difference, that could deal with, the fakes and all the other stuff. That we agree upon, and then what do you have in your tool chest that'll work? So I jokingly, for those of you who are a little bit older, if you remember the Gong Show, it was on television a few years ago. We have run that several times where we invite anyone in who's got an innovative idea that improves care, improves outcomes, and that addresses affordability, and we'll listen to them. And we'll try to find a way to pilot it. We're doing that with ambient listening for our clinicians. That's been a big space. So we had a bunch of things that we saw the last couple of days. Everything from sensors that they were using with the military to determine if a uniform was wet, was it blood or was it water?
Remind me how many patients generally your health system deals with?
So we'll see about 2.5 million patients a year.
Yeah. I ask that because, all the startups that I work with would love nothing better than to get in with a health system that would plug them into a big patient population. It's the $1 million sort of ticket. What are you looking for in an innovative startup that would show you that they're ready to take on a health system?
Yeah, so typically what we look for, obviously, is we want to make sure that the service, the product, the solution is sound and solid and stands up. We want to be able to pilot it, and because we have 7 million lives that we insure, 2.5 million patients that we see, and if we can take a device or whatever it might be, and one of our strengths is our ability to put it into the marketplace fairly quickly, but our objective is that they all have to be scalable. So we don't want to do it for 10 people. We need to know that if this works, that we will approve it for payment, and we will roll it out and make sure it's part of the formulary.
Dr. Nevin, same question for you. I'm particularly interested in your view on the home and care being extended into the home as well.
Yeah, absolutely. And I would just, again, I think David and I, we do have a partnership, and we tend to agree on a lot of things. So I agree with everything that you said. Yeah, I mean, I think my worry about all of this is you may know that traditional healthcare is not generally very adventurous. We tend to be very traditional. And I worry that we are going to sort of lose this moment in time because the technology opportunity, particularly I think with AI and generative AI, to really solve for some of these big issues that we've struggled with for decades, the time is now. And so I think it is absolutely imperative that we work together and we work with these new companies so that as they're creating their product, they can deeply understand the problems that we're trying to solve. I am a firm believer that the home can be a really important place for care. We have long had a primary care at home program for the frailest of the frail elderly. It gets excellent outcomes, and it is significantly less expensive. It costs Medicare much less when we take care of patients that way. We more recently launched a hospital at home program using the CMS waiver. So patients who qualify for admission, an inpatient admission to the hospital, can now be taken care of at home. And the technology that supports that, again, has been tremendous. Patients absolutely love it. Families love it. It solves for some of the issues around equity, frankly, because it helps solve for culture and language and food and so forth. The quality outcomes exceed those in a bricks and mortar setting. And again, we're still trying to better understand cost, but it's extremely promising, again, that it's a way that helps us get to more affordability. We recently launched essentially skilled nursing care in the home, and our vision is to be able to provide the continuum of care in the home. And again, to me, we pilots and dabbling are really important. I would love to see this happen at scale, and not just at Christiana Care and I think 130 health systems that are doing this, but this becomes a different way of providing care. It's better, it's safer, and it costs less.
Michael, what tech convergence are you most excited about?
I'm excited about the timing. So there's a tendency to think that everything we see is the first time in history. And there's this thing called the productivity paradox, that if you look at introductions of general purpose technologies, like if you go back to electricity, when factories got electricity, they didn't redesign the work, they replaced the water wheel with a big central motor. And it took 10, 15, 20 years to figure out that you could redesign the work around the new technology. Same thing happened in banking with the introduction of computers. It wasn't that ATMs appeared when computers first came in. Well, when did we first digitize US healthcare? 10 to 15 years ago. And so from a historical standpoint, we're at the right time where you might expect to see care actually get redesigned. We certainly see that with partners like Highmark of doing these really leading edge things for it. And so I'm especially excited about the fact that the things that 2 years ago, no lab in the world could do them. 9 months ago, we got it working, nearly melting the research computers, and now our partners can actually build on top of it in a way that changes who can design the final mile of technology. I'm excited about that.
Diogo, over to you.
I'm excited just about bringing it all together and what you can do. One of the reasons why I'm excited about that is because I'd like to get rid, to the extent possible, of patient-reported outcomes. That's the endpoint of many clinical trials. It's how the patient feels versus some objective measure. And many of you that are healthcare providers will know some of these standards, like the 6-minute walk test, which measures how far can you walk in 6 minutes when you're in a doctor's office. Maybe you're having a good day, maybe you're having a bad day, but you're getting 1 point in time. Or if you want to measure whether your medicine affects sleepiness or prevents daytime sleepiness, there's a thing called the Epworth Sleepiness Score. You ask the patient once every few months, how often do you feel sleepy doing the following 8 activities? And you get a single point in time. Why do we need to be doing that when we're in 2025 now? We're all wearing these on our wrists. Why do you need to have somebody do a 6-minute walk in the doctor's office instead of taking in all of that data over the past 6 months? We've actually done that in some of our studies. We've added on actigraphy in the middle of a study that still had a patient-reported outcome, because that's what the regulators like to see. And we've seen that, wow, you can get so much richer data. You can find out that not only is the person walking and awake during the day, but they're actually active and they're doing better on the medicine. You can get much, much, much richer data if you bring it all together and you look at it holistically. So I would just like to bring all of this data together, converge everything, take a look at it, let the machines do the work, let the machines do the interpretation, and get ourselves out of the business of looking at single data points spaced weeks or months apart.
I've got a follow-up that I want to ask to the whole group, and whoever wants to jump in. It's really about taking action. Dr. Nevin, you'd said you don't want to miss this opportunity and that we're at a specific moment in time. I couldn't agree with you more. And we've got a room full of people who can be change makers, who can really take action in their sphere of influence. And so I want someone from this group or multiple people to make a recommendation about how we can make sure we don't miss this moment.
I think it goes to what we've discussed, is we really have to work together. Healthcare is extremely complex. And I know we've probably all had the experience of, a great piece of technology has been created, but no one has really thought about how it's going to function inside the health system. And we have got to work together. I think David mentioned that we have a partnership. We have a very unique joint venture between our two organizations. We do not have an insurance arm. And we both organizations believe we need to change care delivery. We need, at the same time, the opportunity is to change how it gets paid for. And because we are having those conversations, we're also talking about how can we then use technology to solve for some of those vexing issues that get in the way of being able to do that. Having technology partners in that conversation and early in that conversation is ultimately going to be the most helpful.
David, your thoughts on encouraging collaboration in this environment that is naturally builds silos?
Well, I think at least my experience has been that when you you have your incentives aligned, you have your metrics aligned. It really is a three-legged stool. What you measure, what you evaluate, and what you compensate for ultimately changes. And Lilly and Highmark and AHN in Western Pennsylvania, proved that during the pandemic, where we were able to put shots in arms for 650,000 people and stem the tide during the pandemic. And what that took was everybody taking themselves back one step, all the A personalities, and instead say, what are we solving for? How do we get this done? And let's go. And I think Janice, just the work that we're doing in Delaware together, The thing that we've eliminated is it's full risk, up and downside risk. And so when her docs are saying, no, this isn't what works, we're changing medical policy and we're trying to address that, or we're showing things that are working in other markets that they might want to consider.
Yeah.
Can I take a dissenting view to part of it,
Please.
or maybe a caution? I think there are a lot of great examples of collaboration, like between Highmark and Lilly that you mentioned, but there are also some really bad examples of collaboration where it's had tragic consequences. Anybody here want to see greater collaboration between insurers and pharmacy benefit managers? I hope not, because guess who gets screwed if that happens? We all do, right? There has been a lot of collaboration in this industry that has worked against consumers, not for consumers. In fact, one of the things I only recently discovered is that 80% of the cost of your medicine, when you buy medicines, the total cost is actually not going to the manufacturers. Maybe if it were 8%, you could kind of understand it, an 8% commission on any other product you buy, but 80 is crazy. So there has been all of this collusion, this excessive collaboration, I would say, that happens downstream at the expense of the consumer. So I think we need excellent collaboration in certain parts. We want great collaboration on the discovery side and clinical trials and things like that. But on the consumer side, I'm not so sure I want to see more collaboration. I want to see more competition there to help bring down the cost of medicines and the cost of healthcare.
I think an interesting topic for this panel as well is just as we look at the incredible increase in the amount of data that we have available, these streams of data coming in, we have both opportunity and risk. When we think about drug discovery on one end, and on the other, provider burnout and click fatigue, alarm fatigue. And so I'd love to hear kind of where you feel like we're at in terms of the opportunities and threats of managing the amount of data that's coming into the system. Maybe, Michael, you could start and we'll go from there.
I have mixed feelings about this. So number one is and you asked sort of for people in the room, and I don't know everyone in the room, that's for sure. What are the things to think about? One is to respect the complexity of care delivery. And so I'll give an example of if you have a 500-bed hospital, you might have 2,000 nurses to staff a 500-bed hospital, maybe 1,500. Before you start applying rules, how many options are there for your staffing choices tomorrow? Well, the number is larger than the number of atoms in the observed universe. Okay, that's a problem we've had since the inception of hospitals. And that we've had those data for a long time. We now have techniques that may be able to help with them. And so one of the things that we think about is what can we learn from other industries that may be useful for healthcare? So supply chain optimization is something that many organizations outside of healthcare are really good at, and we have lots of technology to support. So are things like scheduling and optimization of the most important resource that you have, which is your burned out clinicians, right? So one are things like that. The second thing that I would say is that, again, patient-centered care doesn't care where the patient is, would be, your question before posited that there has been no convergence. But if I ask this room, who's been to the doctor, and then who, when you went home, Googled up what the doctor told you to double check it, a lot of people would raise their hand for that, right? Or heaven help you if you had to switch primary care doctors and you try to find a new primary care doctor, who's used the internet to try to help you do that? Everybody would raise their hand, right? The data would say 70% of people. And if I asked the same question of who's used, Gemini or Claude or ChatGPT, a lot of people would raise their hands now who a year ago would not have. So I think we're seeing that convergence without the traditional healthcare system. And what we're hopeful for is that by making the tooling available for healthcare delivery groups, healthcare payers, medicine and device manufacturers, that we'll be able to accelerate by us doing 85% of the work that you have to do, and the 15% being done by the people who are expert in it.
David, to you, how are you balancing just all of this data coming in, the power of it, making the most of it, while still thinking about just the mental health and well-being of your providers as they manage at the bedside?
Yeah, I mean, I would say a couple of things. First of all, there's a gentleman named Richard Clark in the audience who heads up our data analytics, came out of Carnegie Mellon. You know, we went out and we found a bunch of smart people at Carnegie Mellon who knew nothing about healthcare. And then we said, how can you help us take this information, all this knowledge, both on terms of clinical data, claims data, and unstructured data, you know, the devices, et cetera, and do something with it. So we partnered with Google and said, let's, you know, we need your help on how do we, you know, build the big engine. And, you know, we're challenging our people to then take all that complex information and simplify it. So going back to my, you know, retail roots, you know, in retail, when you talk to somebody, a salesperson in a store, you know, if you ask them to do something, you need to understand that you have to write in a language that allows them to start working on the project or read it, put it down, go help a customer, then come back to it in 5 minutes and pick it back up. So if you write in paragraphs, people don't pay attention. If you write in, you know, in bullet points, you can get things done. We're doing the same thing with everything that we're doing. You know, we're using, you know, the data, and then we're using journey maps, consumer journey maps for different disease states, cancer, you know, heart disease, whatever it might be. And, you know, and we're trying to make it so that the average person can understand it, and we're making it so that it's in a format that the average clinician, you know, who's, you know, got alert fatigue can deal with it. So, and we're also using ambient listening and, you know, all those kinds of things, you know, so that we end the days of our docs doing pajama notes.
A little different spin on this question for you, Dr. Nevin. I felt like when I walked the floor, there was a lack of innovation in provider care, just thinking about the provider workflow, and there's a number of reasons for that. How do you think about the kind of programs that you want to roll out that help providers manage technology and data as it comes in?
Yes, I think there was a strong focus on the consumer, which is great, you know. Yeah, so I'll maybe just talk a little bit about how we're thinking about AI. You know, I think, again, sort of how we've been using AI for a long time. We have I think since 2012, I've had a platform that's now called CareVio that ingests data, applies machine learning, generates risk scores, and allows a care team essentially to manage a population of patients in an asynchronous fashion, and also reach out to them if they see rising risk. So we've been in this space for a while, but obviously the new tools bring with them some additional risks. So it was very important that we created a governance structure inside the health system so it didn't become the Wild West, because again, we're dealing with people's lives. We're also, and the data question is a great question. You know, we generate tons and tons of data. The challenge is how do we use it effectively? For the purposes of AI and using data for AI, we are keeping our data. We have not sort of pulled in data from the internet, again, because we have to be certain that the data that we are using is evidence-based data. So when we're applying analytics and using it, we have confidence that we're going to get the right outcomes. And of course, we always have to be concerned about privacy.
Awesome. One closing question. I want to give each of you a chance to respond as a sort of just a last thought. If we were to come back 10 years from now and have a reunion panel and talk about all the things that we have worked on, what's one advancement that you hope that we would be celebrating on that panel? We'll start with Diogo, and as a little bit of a wild card question there. So what do you think?
It is. I would like to see some breakthrough medicines out there. I think we need to focus a lot more on prevention rather than treatment. If I walk into an emergency room right now, I'm going to pay about 3% out of pocket. If I go to buy a medicine right now, I'm going to pay 20% out of pocket. These perverted economics drive people to avoid preventing treatment and going and getting it when they need it later. And we need to stop that. And I would like to see more medicines that are cheaper, more available for everyone so that people don't have to go to the hospital unless they really, really need to.
Dr. Howell?
10 years is a long time. I think we'll see medicines that have been discovered that cure things that we think are incurable today or require mechanical support today. I am hopeful that we'll see the democratization of expertise in a way that makes that number of 4.5 billion people who don't have access to essential health services much smaller. And I think technology is the only way to get there. And so I'm hopeful for the first time in my career that technology may play out in a way that leads to billions of healthier people on a planetary scale.
10 years from now, I will have closed hospital beds. The hospital will be purely for intensive care, high-tech procedures, a place where women will deliver babies. And I'm able to do that because so much of the care has moved into the community, the home, into ambulatory settings. A lot of primary care can be done with AI. And so 10 years from now, we've got healthier communities, healthier people. We're managing chronic disease so much more effectively that I can shrink those acute care services.
Last word, David?
10 years from now, I think we will have made a big impact on chronic disease. I truly believe that. I think between the innovation that's available to us, but more importantly, using artificial intelligence and the computing power that is in front of us over the next decade, I think can really knock down some serious issues. And I think we got to get away from sick care and start focusing on being upstream and really helping people stay healthy and give them the information that will allow them to do that.
Well, 2035 will be, it's both a long time and a short time, so maybe we'll be back here to talk about it. So thank you, everybody. Thank you, panelists, for taking the time, and thank you, everybody, for taking part in the panel.